Well, welcome everybody. Good evening. Thank you so much for being with us this evening. My name is Katira Noviello Kapoor. I am the Senior Director of Health Promotion, Wellness, and Athletics at the 92nd Street Y. And we're very happy that you could join us tonight for a discussion on colorectal cancer, health prevention, screening guidelines with Dr. Krigel, who we'll talk about more in just a moment. And I just wanted to take a moment to let you know that 92Y is actively building out a new health promotion and wellness division. We are affectionately calling Spark Your Health for the whole of your life. So stay tuned. As you can see from, if you registered for this event, or Elizabeth would have passed this information along through the Himan Brown program. We do have a cancer roundtable series going on monthly up until May. So you can join us in April and May as well. And I'll be sending those links out in the chat. And we should have many more opportunities for health and wellness learning, as well as in-person and virtual programming as well. So stay tuned on that. And just a quick housekeeping note, we will leave time for Q&A at the end of the event and potentially along the way. So feel free to just be typing your questions into the chat, either to the group or you can send them to me directly, and we'll make sure that we have time to answer as many questions as possible at the end. And with that, I'd like to pass it over to my colleague, Elizabeth Tarr, who is the Associate Director of the Himan Brown program, and she will give an introduction to Dr. Krigel.
Thanks so much, Katara. Hi, everybody. Thank you so much for joining us tonight. As Katara said, this is the second talk in our cancer screening roundtable with Columbia University Irving Cancer Center. And we're so happy to have Dr. Anna Krigel with us tonight. Dr. Krigel is a gastroenterologist who specifically went into her specialty because she had an interest in helping people to understand and screen for colon cancer, which is really one of the few truly preventable cancers if caught early. So Dr. Krigel is the Associate Program Director of the Digestive and Liver Disease Fellowship Program at Columbia University Irving Medical Center. She's published extensively on colon cancer screening, early onset colorectal cancer, and the quality of colonoscopy. In addition to her background as a gastroenterologist, she has a master's degree in patient-oriented research from the Mailman School of Public Health at Columbia. Dr. Krigel will speak to us tonight about current research in colon cancer screening, symptoms to be aware of, different screening methods, and she will graciously take questions at the end of the evening. So I also want to say a very special thank you to my colleague and longtime colleague and friend Karen Schmidt, who's the director of the Manhattan Cancer Service program at Columbia, who helped us arrange this whole series. So Dr. Krigel, thank you so much, and I'm going to turn it over to you.
Thanks so much for that introduction. And I'm so happy to be here speaking with everyone tonight. I'm going to share slides and get started. So as a gastroenterologist, I do lots and lots of colonoscopies, and I see patients for the purpose of colon cancer screening and also for polyp surveillance, colon polyp surveillance. And so we'll get into all of that. And that is my academic interest within gastroenterology as well, is colon cancer screening and prevention and quality of colonoscopy in general, making sure that we're being as effective as we can when we do colonoscopy. So tonight I wanted to speak with you all about colon cancer screening. It's not just colonoscopy. There are other methods that I wanted to make sure everyone's aware of. And also what the latest is on the guidelines about when we should be starting colon cancer screening, how long we should be doing it for, when we should be stopping, and how frequently we should be doing it. So with that, I'll get started. Please interrupt me with questions if you have them, or we can certainly answer questions at the end if you enter them in the chat. So colorectal cancer is the third most common cancer in the US in both men and women. It's the second deadliest cancer in the US. 90% of cases occur in people 50 and older. However, that does mean that 10% of cases occur in people younger than the age of 50. Rates are slightly higher in men, and you have a higher risk of colon cancer if you have a family history of colon cancer or a history of inflammatory bowel disease like Crohn's disease or ulcerative colitis. With family history, if you have a first-degree relative, meaning a sibling or a parent or a child who has had colon cancer, that really puts you in the higher risk category. Having one second-degree relative, like a grandparent or an aunt or an uncle, doesn't quite put you in the high-risk category unless you have multiple second-degree relatives with a history of colon cancer. But certainly a first-degree relative puts you in a higher risk category where we would actually start screening earlier. We'll get into that. The benefits of screening. So 2 benefits of colon cancer screening. First of all, preventing cancer in the first place. And how do we accomplish that with colonoscopy? Well, when we do colonoscopy, we can actually find precancerous polyps, which are small growths in the colon that are benign, but they have a potential to grow in the future. So a certain percentage of polyps in the colon will grow in the future. And so what we do during colonoscopy is we look very carefully for these polyps. They can be very small, they can be on the larger side, and we remove them when we see them to prevent their growth in the future. And so we can accomplish cancer prevention. And then the other thing that, of course, we do with any cancer screening test, including colonoscopy or other colon cancer screening methods, is that we can improve survival from colon cancer by detecting colon cancer when it's still at an early age or early stage before it causes symptoms. So before a person presents with symptoms of colon cancer, we can find it, detect it early when it's still at an early stage, when it's treatable and even curable. So that's why we do screening. When do we start? So there actually have been changes to this guideline in recent years. We used to start screening for all average risk people, meaning people without a family history or a history of polyps, at the age of 50. But in May of 2018, the American Cancer Society came out with an updated guideline that actually says that we should be starting average risk screening at age 45 for everyone. And that is based on the fact that in the last decade or so, we've noticed an increase in colon cancer incidence in younger people in this country. And so now screening begins at age 45. The other guidelines followed suit. This is the U.S. Preventative Services Task Force draft recommendation from October 2020 that was eventually then taken up in 2021. And the reason why it's important that the U.S. Preventative Services Task Force also agreed with the American Cancer Society is that health insurances go along with the USPSTF's recommendations. And so now it is recommended by this society and now all societies that make colon cancer screening recommendations that we begin at age 45 for all average risk people. For people with a family history of colon cancer and a first-degree relative, the recommendation is to start earlier at age 40 or 10 years before that relative was diagnosed, whichever comes sooner. But this is the recommendation for average risk people. When do we stop screening? So the guidelines say that if all prior screening tests have been negative from 45 to 75, you can consider stopping screening at age 75. And if all prior screening tests have been negative, recommendations are to stop screening, just stop at 86 and above. So between 75 and 85, we have this period of time where it's a discussion between the patient and the provider about preferences, about the procedure itself, about how healthy the person is to undergo screening. And that's sort of that period in there. If, of course, you've had screenings before and you've had polyps, that puts you at slightly higher risk. And so you'd be more likely to be offered screening after age 75 and beyond. But certainly if you've been screened at regular intervals and you have not had any polyps through to age 75, you can consider stopping, but definitely stop at age 86. So in terms of screening methods, so it's not just colonoscopy. These are the 6 methods that the American Cancer Society says are acceptable for average risk people, but they are different in quite a lot of ways. And so I want to go through the advantages and disadvantages to all of them. So first, we have our category of stool-based tests for colon cancer screening. There's 3 different stool-based tests that I'm going to go through. And by stool-based, I mean you give a sample of your stool, and it's tested for certain things to look for or detect colon cancer at an early stage before it has presented with symptoms. Then there are the structural examinations. Colonoscopy is the most common. There is a CAT scan form of colonoscopy that is not as commonly used. It still involves doing a prep for the procedure. It's not, say, the most comfortable to do, and it's not all that widely available, but that is out there. And then flexible sigmoidoscopy, which is basically half a colonoscopy, you don't go in as far, has essentially fallen out of favor recently, just because we do know that polyps and colon cancers can live in the other side of the colon that you don't get to in flexible sigmoidoscopy. So it's much more common now to be doing colonoscopies if you're going to undergo a structural examination. So, and then of course, what is next to these is the intervals at which you should be getting these tests, because colonoscopy is the most sensitive for detecting both precancerous polyps and early colon cancers. If you have a colonoscopy and you have no polyps, you only need one every 10 years. It's that sensitive, and polyps grow that slowly. If you have one of these stool-based tests, it's either yearly or every 3 years. So that's the first difference, but I'll go through them in more detail now. So in terms of the stool-based tests, the first that was on that list there is fecal occult blood test, or FOBT, which detects microscopic blood in the stool. There's a picture of it on the slide there. It's a card where you put a sample of your stool, and then a solution is put on it by the lab to detect microscopic blood that you can't see with the eye, but that is present and can be present from a slowly bleeding mass or tumor. It requires 3 stool samples, and it also requires dietary restrictions because unfortunately it picks up iron that could be present in your diet. And so you have to change, in order to adequately do this test, you have to change your diet in the days leading up to doing it. It must be done yearly, and it's not as sensitive compared to the other 2 tests that we have that are stool-based, that I'll go over next. So this test is not as highly recommended as the other 2 stool-based tests if you're going to go the stool-based testing route. FIT, or fecal immunochemical test, is a test that specifically looks for human blood in the stool. So you do not have to adjust your diet at all before you have this test. You only need 1 stool sample as opposed to 3. It still must be done yearly, like the fecal occult blood test. It's low cost, which is an advantage compared to Cologuard, which is the one I'm going to go through next. And you also get fewer false positives compared to Cologuard. However, because it's slightly less sensitive compared to Cologuard, that's why it needs to be done yearly. Cologuard is the last stool-based test that we have. It's a combination of fecal immunochemical test and DNA testing. So what the Cologuard detects is not just microscopic human blood in the stool, but also DNA that can be associated with an early colon cancer, which makes it slightly, as I said, more sensitive than the FIT test. It needs to be done every 3 years instead of every year because of that, because it's more sensitive. Again, it's a single stool sample. But with that increased sensitivity, you also get more false positives, unfortunately. So that's a downside. And then the other downside is that it is more expensive than the FIT. But, you know, both are very good if you're of average risk and you do not want to do a colonoscopy. These are both very good options. Advantages being you don't have to go through a procedure with sedation, which is what colonoscopy is. You don't have to go through the prep process for colonoscopy. There's very good detection for early colon cancers, as I said, before they cause symptoms. But you are not getting the advantage of detecting and removing precancerous polyps. If you have a positive stool test, also, your doctor will recommend that you then undergo colonoscopy. So, you know, if one of these tests comes back positive, you're doing a colonoscopy anyway. But I always tell my patients who are of average risk that this stool-based testing is available. It's an option. And I just go through the positives and the negatives. And it's really up to my patient's preferences. What's more, you know, what do they value most in a cancer screening test, what their preferences. So now I'll discuss colonoscopy, which is, you know, the most common and most sensitive method for colon cancer screening. It accomplishes directly colon. So the picture there shows you that flexible scope with a camera at the end is inserted through the rectum and then through the entire colon. And you can see, you know, you get direct visualization of the whole thing. You can detect cancer and all precancerous lesions, which are polyps. In a single session, you get both diagnosis and therapy, meaning you can diagnose polyps and cancer, and you can also accomplish the removal of precancerous polyps. And because it's so sensitive for early colon cancer and polyps, you have longer intervals between normal examinations, as I said, 10 years. But even if you have 1 or 2 small polyps that are under a centimeter, but precancerous, you don't need another colonoscopy for 7 years, the guidelines say. If you have more than that, well, then we consider you higher risk, and it would be more like 3 to 5 years. A word about the preparation, because the procedure itself is generally very well tolerated. You know, you're sedated for the procedure. There's an anesthesiologist in the room who gives you medication through an IV so that you're asleep and comfortable. You don't remember. People generally wake up feeling well from the procedure. You can have a little bit of cramping from the air that's inserted, but generally, you know, you wake up feeling like you've had a good nap. But the preparation for colonoscopy is the more unpleasant part of the procedure and onerous. So what's required? So first of all, we ask you to change your diet in the couple of days leading up to the procedure. We used to tell people actually that you could only have clear liquids the day before colonoscopy, things like Jell-O and soup broth. But in recent years, we've actually liberalized that guideline. We've found that if you follow a low fiber diet in the 1 or 2 days leading up to the procedure, you can still eat solid food the day before and accomplish a good clean out. And so a lot of providers' guidelines for colonoscopy preparation differ, but at least for my patients, I allow them to eat solid food the day before up until the prep begins at 6 p.m., as long as they are following a low fiber diet, meaning they're avoiding fruits and vegetables, seeds and nuts, and multigrains. These are things that take longer to clean out of the colon than lower fiber foods. You'll have to adjust some medications if you take blood thinners. Because if we remove polyps and you're on a blood thinner, that can bleed more than we'd like. So you'll need to speak to your doctor and possibly your cardiologist if you're on any of those medications. That's the main one that we think about stopping. Of course, if you have diabetes and you're on insulin, that's another medication that we adjust just because you're fasting on the day of the procedure. So generally, you're going to want to lower your insulin dose if you take insulin. Then the prep itself is a large volume of a liquid laxative. You drink half of that solution the night before the procedure. It'll give you diarrhea and it cleans out the colon. And in the morning of the procedure, you drink the second half of the solution to finish the clean out. And I tell patients to finish it about 3 hours or a little more. before the start time of your procedure. That way you'll have a little bit more cleaning out or diarrhea the day of the procedure when you're still at home, but then you should be finished and not worrying about rushing to the bathroom on your way into the procedure itself. That large jug that you see in the first picture was, you know, what used to be more commonly used, but we have lower volume preps now available on the market. The one on the right, which is called Soup Prep, you can see that the solution is much smaller in volume. And so I always try to give people lower volume preps these days than that traditional 4-liter jug. And so there's been improvements there in the last several years as well, that it's not as high volume as it used to be. On the day of your procedure, you present to the endoscopy suite where a nurse and or an anesthesiologist will ask you questions about your medical history. You go over the informed consent with the doctor to discuss the risks and benefits of the procedure once more before you have it done. The anesthesiologist places an IV, and then you're off to sleep and you have the procedure done. Lasts about 20 to 30 minutes. Because you receive sedation, you must have someone who can bring you home from the procedure. That person doesn't have to be waiting the whole time, just needs to be available to come and pick you up and bring you home so that we can ensure that you get home safely. Now, what can we find during colonoscopy? So I've been discussing these polyps. So this is what the polyps look like. There's a smaller one in the top picture and a larger one on the bottom picture. There are different kinds of polyps. Adenomas are the kind that are the precancerous and have the potential to grow in the future. Hyperplastic polyps are quite common, and actually they have no precancerous potential. So if you have a hyperplastic polyp or more than one hyperplastic polyp, that actually does not put you at higher risk for colon cancer. And then advanced adenomas, which really that one on the bottom picture is more advanced, meaning it's a centimeter or larger, that puts you at higher risk. And it's a good thing we found it and took it out because it was on its way to growing. And we consider you higher risk at that point. And we shorten the interval of colonoscopy actually just to 3 years if you have an advanced adenoma. But that's what they look like. And what do we do? So when they're this size, this is a common way that we remove the polyp. We place a tool through the scope itself, looks like a little lasso, it's called a snare. We place it around the polyp and we can just snap it off and then suck it up and it's gone. We send it off to the lab to see what kind of polyp it was. Generally, the bleeding from this resolves in front of our eyes. If, of course, it bleeds a little bit more, we can always do things during the procedure like place a clip to close that defect that we created. There's always a small risk that it can continue bleeding, and that's a known risk of the procedure, but it's rare. And if that were to be the case, you might require another procedure to have that defect closed if it wasn't closed initially. But generally, in most cases, this is very minimal bleeding that this causes, and it does not cause pain either. Having a good prep, I tell my patients, is arguably the most important part of the procedure. We cannot accomplish finding these very small polyps if there's stool left over in the colon. We really have to have a good clean out of the colon in order to do a good, thorough exam where we've been sure that we've eliminated the possibility of polyps, or we found small ones that we've taken out. And so if we deem the prep to not be adequate, meaning fair or poor on this slide, then the procedure must be repeated. So it's very important to follow the instructions that are given to you in order to have a good clean out, both the diet instructions and the prep instructions about how and when to drink the prep. And you'll know that you've done a good job with the clean out before you go into the procedure, because your bowel movements will, be totally clear by the end of the prep. After your procedure, you generally recover in the recovery area of the endoscopy suite for half an hour. There's no dietary restrictions after the procedure. As soon as you're feeling up for it, you can go back to whatever diet you were consuming before the procedure. You'll receive a report with pictures and the findings. And if you have no polyps, as we said, your next colonoscopy is in 10 years. And if you have polyps found, it may need to be repeated sooner than 10 years. And that is all.
Thank you so much, Dr. Krigel. So informative. One question that I'm seeing is, oh, and then we'll actually, hold on, let's go over to Sarah first. Sarah's raising a hand. Sarah, you should be able to unmute yourself, but if not.
Yes, I did.
Oh, perfect.
No problem. I do have the family history. My father died of colon cancer, and I have been tested, and I'll be had the last test last year, and I don't know if I'm going to bother again at 86. I've never had a polyp, but it's worthwhile having the test for peace of mind. And we've urged everybody else in the family, even my younger brothers, to have it as well.
Perfect. Yes, definitely. That's a first degree relative, puts you at higher risk. Not only, you know, would you not be considered average risk, meaning that we recommend colonoscopy more so than stool-based testing for people who are at higher risk with a family history. Also, the intervals are shortened. If that person, if the relative was diagnosed before the age of 60 with colon cancer, then we recommend that no matter what, you have colonoscopies every 5 years instead of every 10, no matter what we find. But yes, at the age of 86, at that point, if you've had negative screenings, you know, the risks of the procedure at that point start to outweigh the benefits. And so that's why, you know, we start to recommend against doing it.
Anna, this is David. What are the risks of the colonoscopy in general? What are the different types of risks?
So I went over the one risk, which is the bleeding. So if we remove polyps, you know, we do cause bleeding at that site where we remove it. In most cases, that bleeding, as I said, resolves quickly in front of our eyes. And if not, we can do things during the procedure itself to stop the bleeding. In rare cases, though, we can be surprised, and the bleeding can happen for, you know, anywhere from up to 10 days after the procedure. That would require you to come back in and have a repeat, you know, small procedure to then, you know, resolve that bleeding. It's not that common, but that's one risk.
What would that small procedure be, Anna? What would that small procedure be? Another colonoscopy effectively?
You get right. So another colonoscopy doesn't have to be the whole thing. It just
Okay.
has to be a colonoscopy up to that site. It's the same idea, but up to that site, resolve the bleeding, get out. So it's considered a smaller, you know, procedure, but still a colonoscopy. There's a very small risk of infection anytime we do the procedure. Now we're extremely careful with how we clean the scopes, how we clean equipment, but we are introducing a foreign body into the body. So there's a small risk of infection because of that. And then the other risk is, of course, of perforation of the colon. It's rare. It happens anywhere between, in the literature, 1 in 1,000 to 1 in 10,000 colonoscopies. But that is, you know, sort of the worst thing that could happen during a regular screening exam. If there is a tear, sometimes it can be repaired during the procedure itself, but it could also require surgery because of a perforation. So those are the 3 main risks that we think about for colonoscopy.
Thank you.
Okay, I'm going to ask Ava to unmute.
Yes. What are the warning signs of colon cancer? What are the changes that one might observe?
Great question. Yeah, so I was going over, mostly screening exam for average risk, but, we do colonoscopy for diagnostic purposes if you present with certain symptoms. So bleeding is one of the main things that we worry about. So if you start to have bleeding with your bowel movements, now there are multiple causes for bleeding with bowel movements. A lot of bleeding, if you just see bright red blood on the toilet paper, a little bit in the stool itself, that can be from hemorrhoids or something like that. But if you have persistent bleeding, you should present to a doctor because that can be one warning sign of colon cancer. If you experience a significant change in your bowel habits from what you've had before, if you go from having regular bowel movements to something that's very different from what you had before, that can be a warning sign. And if you have a blood work and it shows anemia that was not present before, that could be a warning sign that you are slowly bleeding from somewhere in the gastrointestinal tract. That would prompt further investigation. And then the last thing, this is a warning sign for any cancer, but if you have unintentional weight loss, you're losing weight, you don't know why, that could be a concerning sign. And so that's another thing that we would maybe prompt a colonoscopy. Those are the main warning signs.
Thank you.
But
Shifting
even without any warning signs, you'd still recommend the colonoscopy, obviously.
Well, yes. Those warning signs warrant a colonoscopy for diagnostic purposes, but colonoscopy is recommended, as I said, with no symptoms at these intervals, at these ages, for prevention of colon cancer or detecting it early without symptoms when it, before it presents with symptoms. That's the idea behind any cancer screening method, is that we want to be finding cancers. And even, colonoscopy is so good that we can even prevent colon cancer, but we want to be finding cancers before they cause symptoms, because often when they cause symptoms, it's advanced at that point. And so with colonoscopy and these stool-based tests, we find these cancers before they cause symptoms. And so, yes, it's important that you get them without symptoms too.
And how accurate are those CT scans you were mentioning, the virtual colonoscopies?
The virtual colonoscopy, it's sensitive for polyps that are 5 millimeters or larger. So you don't get the detection of the really small ones. That's okay. And that's why it's recommended every 5 years instead of every 10. So they are sensitive for polyps in the same way that, stool-based tests are, to make it an acceptable screening method. One of the issues that I didn't go over when I went over that, I mentioned that a prep is still required. You still have to clean out the colon because the CAT scan is looking for polyps and it can't confuse that with stool. But another thing that I didn't mention is that, you can find other things incidentally because you're doing a CAT scan of the whole abdomen. So it's another reason why it's not so favorable. You find other things incidentally, you don't know what to do about them. So that's another reason. But yes, it is sensitive for polyps that are 5 millimeters or greater in size. And so that's why it's recommended every 5 years.
And are there any major risks in doing that one, or fewer risks, would you say, than the other one?
Yeah, fewer risks, and actually, it doesn't require sedation, and so there's always a risk when you have the sedation for the procedure for the colonoscopy as well. Just if you have heart or lung issues, your heart is stressed under sedation, so that's another advantage of that one, that you don't have to be sedated. So yeah, fewer risks than colonoscopy.
Yes, Helen. Oh, I think we just need to unmute. They asked you to unmute. Let's see if. Or feel free to use the chat box as well. So while Helen is working on unmuting, shifting to prevention a little bit, I was curious, and then I saw some questions pop up about if you could speak a little bit about diet and prevention? Because I know there is some research tying like red meats and processed meats to colorectal cancer, and just curious if there are any thoughts towards shifting towards more of like a vegetarian diet or less meat in the diet.
That's correct. So, there are multiple factors that go into your risk of having colon cancer. Oh, should we let Helen go and then I'll get to that question?
Sure.
May I speak now? Can you hear me?
Yes.
Yes.
Please. My father died of colon cancer. I used to have colonoscopies every 3 years, and polyps were always found and removed. Now, I'm 90 years old. Why can I not have colonoscopies at this age? You said that it could take 10 years for a polyp to grow. Does that mean I can look forward to dying at 96?
You can have a colonoscopy at your age if your doctor and your anesthesiologist deem that you are healthy enough to have it. There's no for people who have never had polyps and who don't have a family history, we recommend stopping at age 86. So after age 85, but you're in a different category. And so it's up to you and your doctor if you want to continue with colonoscopies at that point.
I think he's afraid to do them.
Yeah, well, you're, at that age, it's higher risk for you to undergo sedation. Your colon is potentially more susceptible to those risks that come up, like perforation, just because it's a little thinner and more friable. And so, polyps some of them take 10 years to grow, some of them take more than that. So it is sort of it's a risk benefit, and the discussion between you and your doctor at that point.
I see.
It has to do with the risks of the procedure, basically, and the judgment that potentially the risk of you undergoing the procedure would outweigh the benefit of potentially finding a polyp that could grow in the next 10 years, and that's why.
Thank you.
I hope that was a satisfactory answer, but
No, no, it isn't. It's the answer I've heard before. It's not satisfactory.
okay, yeah. Well, I hope it's an explanation at least. And then just to get to the other question, so lots of factors go into your risk for colon cancer. Certainly your diet is one of them. A diet that is high in fiber and low in red and processed meats is generally good for gut health, and good for preventing colon cancer. It doesn't have to mean that you have to be completely vegetarian. Generally it's, but staying too low in diet and red and processed meats is generally better for the colon than eating a diet that's high in red and processed meats. And then a diet that's high in fiber is just really good for gut health in general, and certainly better for the colon. Tobacco, cigarette smoking puts you at higher risk for having polyps and colon cancer. And so that, that's another thing. Certainly being obese, or having an elevated BMI puts you at higher risk. And so of course, exercise helps prevent your risk as well.
Thank you. And I think we have one more question. Elizabeth, did you have?
Sure. So I have a question, Dr. Krigel. I come from a family where my grandfather had 2 siblings die of colon cancer. Everybody else, he had 4 other siblings who were really good about, including him, getting screened and had precancerous polyps removed. So I've had a colonoscopy and I'm due for another one. For someone like me with a distant family history, could I do something like Cologuard, or would you recommend colonoscopy screening?
You could do something like Cologuard. If it's distant, then you would still be considered average risk. If there are multiple family members, though, multiple distant family members, you could also consider just seeing a genetics person, because genetic testing is available for colon cancer syndromes. And so we actually have a genetics group, a GI genetics group at Columbia. If your grandfather never got tested, or your your parents never did. So there is that option to undergo genetic testing if there was a big family history of it. But no, for you with, you know, 1 or 2 distant relatives, you would be considered average risk still.
Okay.
By the way, does the age of your relative who had colon cancer factor into the risk factors?
Yeah, it factors into the guidelines.
Mm.
So if you have a first-degree family relative who has colon cancer, who had colon cancer before the age of 50, or even an advanced adenoma, then you start at age 40 or 10 years before they were diagnosed, and you continue screening colonoscopies every 5 years. If the person was diagnosed after the age of 60, the guidelines actually say that you start at age 40 or 10 years before they were diagnosed, but then you can continue with the screening intervals that an average risk person would after that.
Thank you.
All right, well, it looks like those are all of the questions that we have for now. So we, let me just get Elizabeth on here as well. And Dr. Krigel, we just want to say thank you so much for your time, and thank you to everyone in our wonderful audience for joining us this evening. And we look forward to seeing you back in April and May for finishing up our Cancer Roundtable series.
Thank you so much. Thanks, Dr. Krigel, and thank you everybody for being
you.
here.
Thank you.
Thank you, my pleasure. Thank you for all the
Good night.
questions.
Be well.
Bye-bye.
Bye.